next, I would like to start the program. Can you all hear me okay? Okay. So, I think I just want to recollect, what happened during the year. We had, some of the best programs that we hold. And we had healthcare, we had, the financial panel, we had folks from different large financial institutions. And I think what I heard from the community and people who came in said, oh, this is amazing. Because it's not only business, there was not only business to business connection, but also people develop friendship. And today, I personally feel that my friendship, I owe quite a bit to TiE. I have people from Orange County who are coming here, Ravi Sharma, MK, who's our president from Orange County, he's here. So we developed friendship for a very long time. The other thing that has happened is we created, this network, and I came across very good entrepreneurs, amazing entrepreneurs, both women and men. I am really amazed by what Venu is doing. She's an amazing entrepreneur. If you look at, she's an oncologist with an MBA from Wharton, and she is right now, like what Anderson says, she wants to, put an X across cancer. So amazing, so that's what we have done. And then, we had very, I think partners. These partners came in, and if you look at all the big names here, thanks to Trubian, Jay Srimalson and Dina, and we had Sharp, we had Qualcomm, we had amazing fireside chat with Christian Oman, CEO of Qualcomm, and also, some of the companies that presented here were acquired. For example, you see Cardia. Cardia was acquired recently. It's a biotech company. They're doing, chip for biotech, for blood analysis and predict certain diseases. So they were acquired, and I think this is becoming now a phenomenon in Southern California. So next, what I would like to announce is we have this huge event. It's our premier event. Of course, this is also a premier event coming up. This is our Shark Tank, TiE Shark Tank. And this is going to be at the Sharp Innovation Center. Sharp Innovation Center is brand new. It's called Sharp Perils Innovation Center. And Mike Reagan, who's on the right side, he's sponsoring us. He's the Chief Information Officer and Innovation Officer at Sharp. He is amazing. I think he's not your, I would say your old school CIO. He is very forward-looking. He has changed so much in Sharp. When you see what he has done, it's amazing. He's brought cloud, he's putting analytics, AI, all that into his programs. So I think, and we are expecting, we have seen a very good traffic in terms of registration. And then Mike himself personally is going to give a tour of the Innovation Center. I think they have different simulation centers and all that. I think you'll enjoy that. But I think this is a really premier program. We have selected startups to come and pitch for their Shark Tank Award. And then we also will have several demos that you can touch and feel what AI is. And we have folks like Microsoft, Qualcomm, and CXApp, which is my company, going to demonstrate what AI is. So I think you'll get to see all that, and I think we are really excited. Now, I think, our chapter, our pillar of the chapter is charter member. Charter member has a lot of say in what we do. And I think I would, say that I've been a charter member myself, and folks here, quite a few of them have become a charter member. But I think being a charter member is really, it's about giving back, about establishing network connection. I think a lot of folks have benefited in terms of business, mentorship. I've seen a lot of startups take off. So with that, I would like to bring one of our charter member, Venu Prabhakar. Dr. Venu Prabhakar is chairing this panel. And Venu, please introduce the panel.
The first one is Farris. Where are you? Farris. She has been a dynamic leader in San Diego area. We have an organization called SAPI, San Diego Physicians of Indian Origin, and she is the current president. She has been a primary care physician, and just like me, and she identifies and agrees with me the amount of frustrations we encounter, and that's one of the reasons why she chose this topic of perils of primary care in the future. So this we need to let everybody know, and she's going to come and talk to us. Okay, thank you very much, Farris. And the next one is Harish. Harish is a very well-known orthopedic surgeon in San Diego. So for some other reason, somebody wanted his resume. So he sent me his resume. And I called him back and said, no, erroneously you sent some other document. He says, why? There are 54 pages. No, that's my resume. So he has got enormous amount of credentials. I cannot just go over all of them completely. So he is going to join us as well. And maybe I can introduce myself as well. So I've been San Diego since 1987. 37 years I've been in practice. I recently retired, and one of the company which bought the practice, we are going to grow. They made me the director of strategies in that company, so I'm going to be doing that. As far as almost the entire career of my professional life, I've been a teacher. I was an assistant professor at Stanford for about 8 years, and after that, here in our office, I used to have students, medical students, residents, PA students, nurse practitioner students, everybody rotated my office from UCSD, UCI, USD, Yale University. Don't ask me why. San Diego is the hot spot. Students prefer to come there. So, many, 14 different universities they used to read. That's what I'm missing. When I retire, I miss my patients and I miss teaching. So, anyway, thank you very much, TiE organization, for giving us an opportunity to talk. Thank you.
They should be in the slide. It was for you. What we need. Is he going to see it? Is he going to see it? He's not moving. So maybe I should go and see. I told him. Yeah, no.
While Venu is getting ready with his presentation,
I'll like to thank our sponsor, Knobbe Martens. They've been so kind and generous to give us this absolutely fabulous facility. Hans, could you please stand up? Please give a big hand to them.
Here's Dr. Sandhu. Okay, go ahead.
Thank you, everyone. Thank you for coming out after a long, hectic day at work and coming to listen to us. I also want to thank TiE, especially Naveen Stoney, Sandeep Verma, Vinay Bhagat for organizing this event for us. Thank you so much. My topic for today is simple but very important topic. The dismal future of primary care. So what is primary care? A primary care physician is a physician who takes care of you as a whole, not just focused on one particular organ system, but as a whole. The idea behind primary care is to have a longitudinal relationship with the patients and their families, have a meaningful impact on their lives, ameliorate human suffering. So here is some statistics. I'm sure many of you might be knowing this. 10,000 baby boomers are turning 65 every single day. So, the number of primary care physicians, if you take the total number of physicians, slightly less than 50% are primary care physicians. Out of those primary care physicians, 47% of them are age 55 or older. Average age of retirement for all physicians is 60. Now, you can see here, with the aging population, we are going to need more primary care physicians, especially because the aging population is going to have the chronic medical conditions which need to be taken care of by your primary care physicians. But, unfortunately, as you see here, age 55 or older, average age of retirement 60, so in the next few years, I'm going to say 4 to 5 years, about 50% of the primary care physicians are going to be retiring or are about to retire. All right, this is another statistics. The estimate is there's going to be a 21,000 to 55,000 shortage of primary care physicians by 2032. This is the 2016 statistics where when Americans, they go to an office, total number of visits to go to a physician, including all the specialties, is 900 million in a year. Out of that, 410 million is just for primary care. So you can see about half of the visits are for primary care. According to the Center of Medicare and Medicaid Services, the healthcare spending reached 3.6 trillion in 2018. In 2022, that came up to 4.4 trillion. It's going to go up further to 7.2 trillion by 2031. Out of this amount, out of these trillions that we are spending on healthcare, primary care costs were only 5 to 7%. Sad, very sad. And then, this is another very staggering statistics. Over 100 million Americans do not have access to primary care physician. We're talking about almost 1/3 of the US population. So, what is the reason? Why is there a primary care shortage? Yes, of course, as I predicted, as I said in my earlier slide, many of them will be retiring due to age, due to burnout. Yes, that's a reason. Who's going to take their place? It's going to be medical students. But those medical students who are currently in training and will be needed in the force over the next 4 or 5 years, when many primary care physicians are going to be retiring, are not even choosing primary care as a career because they witness the enormous workload, overwhelming overhead, and then of course the reduced income compared to the specialists. And then we have the residency program positions. These are funded by the Center for Medicare and Medicaid. So, since 1997, that residency slots, they have remained static. Now, finally, a couple of years ago, they came up with, okay, let's go on and increase the residency slots. What did they do? 1,000 slots over the next 5 years, which is just 200 slots every year. Okay, so this is another little graph that I thought I should mention. So if you look at the number of practicing physicians per 1,000 population, you will see US near the bottom of the spectrum. 2.6 physicians every 1,000 population, as compared to all these developed countries. Look at Norway, 5.2 physicians per 1,000 population. And then this is another statistics. US adults are the least likely to be able to see a primary care physician if they need you after hours. US, bottom. 45% of the primary care, only 45% are available after hours for you. While if you go and see the other developed countries, look at Germany, 96% are available after hours to do the work. Why? Because the primary care physicians are just exhausted. They're completely done by the after hours, by the weekend. In fact, do you know what they're doing? They, after hours, not seeing patients, they're completing their paperwork. Okay, so that's another one. So the average waiting time in 2022 to see a primary care physician was 21 days, 3 weeks at least. If you go to a primary care physician, the office visit would be on an average about $100 per, if you go there, right? But then at the same time, if there's an emergency room visit, that cost goes up to $3,000 on an average. Then hospital cost, $25,000. The most common reason for hospitalization is high cholesterol or the complications of that, high cholesterol, hypertension, diabetes complications, heart failures. Now, if these chronic medical conditions were managed over here with the primary care physician, the cost would be much less. Why is the cost staggering? That is the reason. These could have been taken care of over there, but there are not enough primary care physicians. Nobody even wants to go there. You can see the cost for these above conditions in 2018 was over $40 billion. With the primary care shortage, of course it's going to go up 2 to 3 times easily. All right, so what is the proposed solution to this? The proposal is, let's get the mid-levels to do the job. And the mid-levels are physician assistants, nurse practitioners. And now, CVS, Walmart, Walgreens, they're all lobbying to allow pharmacists to see patients. I am so sorry about that. Look at the training level. Here, there is a primary care physician, after 4 years undergrad, 4 years of medical school, 3 years of residency, 7 years at least, and then we have the physician assistant, 1 year of medical education, 1 year of clinical rotation, and now they are called physician associates, partners. And then we have nurse practitioners, nurses who are getting upgraded to be providers. 2 years of clinical office rotation. Now this office rotation, mind you, is not every single day. It's just 1 to 2 times a week. Can you imagine? What is practice of medicine? Practice is, when I go there, I treat a patient. Patients, you learn from your patients. If there is no continuity of care, how do you even learn? How do you practice? How do you become more efficient? In California, unfortunately, nurse practitioners are allowed to practice as doctors. In fact, they want to be called as doctors. Okay, look at this. Can you imagine any one of you, this patient in so much distress, lying on her couch, just wanting to see a primary care physician, calling all over. No, she's not able to see a primary care physician. So the next step is, she will be going into the emergency room, waiting there for long hours, and then ultimately getting seen. And of course, the cost of healthcare goes up. No doubt about that. Burnout. So yes, the incidence of burnout amongst physicians, 60 to 65% on an average. Certainly, it's much higher for primary care physicians. Why? Here are the reasons. Higher number of patients we see every single day. So that patient is not just a simple, just a one complaint patient coming to you. The moment they get an appointment with a primary care physician, they start making a list. I am going to go head to toe. Why? Because it's not their fault. It's not the patient's fault. They've not been seen for so long. They've been trying to get an appointment here, and no, they could not get an appointment. Now I'm going to have all my conditions addressed today in that 15 to 20 minutes appointment. So all these conditions that they want to address today is on top of the chronic medical conditions that need follow-up as well. So that we do in 15 to 20 minutes, right? On top of that, that 15 to 20 minute appointment, we're even supposed to take care of all the quality measures, the preventative stuff. Prevention is better than cure. I strongly believe in that, right? So yes, colon cancer screening, breast cancer screening, cervical cancer screening, prostate cancer screening, everything needs to be taken care of. If you don't do it, you're penalized for it. Primary care physicians are penalized for it. Then, of course, the way you code, it's called a RAF score by the insurance companies. If your RAF score is reduced, you're penalized for it. You're not making enough money here, right? So this spelling is a little wrong, I'm sorry. Physician burnout is costing the healthcare system at least $4.6 billion every year. Okay, more on burnout. Why? So it's not just about seeing patients. When a patient comes to be seen, they think we're done with them. Everything is all set. No, the real work is starting afterwards, right? The real work is completing the charts. And this happens, mind you, after office hours. This happens on weekends. Completing the charts, answering messages from the patients, refilling the prescriptions, reviewing the labs, radiology, consultations, and if there is something abnormal, I have even called a patient at 8 o'clock in the evening. You need to go to the emergency room right now. And then, of course, writing letters to the insurance companies, you have to advocate for a patient, right? So you do the authorizations for medications, for referrals, for tests. So that's what happens after hours and on weekends. Okay, all right. So before this slide, I want to just say one more thing. So what is the proposed solution for that burnout? According to the organizations, or the bigger organizations, right? The solution for burnout is on the physician. Physician wellness. Do yoga, do meditation, but take care of the patient. Nobody is addressing the white elephant in the room. Nobody. Okay. And then, of course, we have the devastating economic implications of primary care physicians. They have to hire more people to take care of all these things. More front and back office personnel, referral coordinators, scheduling the patient for quality measures.
That's Sameer.
Many of you know.
Is that Sameer in the picture?
It looks like Sameer. Sameer, yeah, it looks like you.
Thank God he's not a primary care
Yeah. So yes, during COVID, there was a tremendous loss to the primary care physicians. It's estimated to be $15.1 billion. The physicians and their staff, some of them had COVID, and then financial loss from the quarantine period. And of course, there was a dramatic reduction in patient load. That's just one of the statistics, which I'm sure many of the specialty departments also went through, but I just thought I'll just include that. Okay, so this is a typical primary care physician here. Just look at this picture. This could be me sitting there, right? So first, this is one of the staff members. Doctor, the emergency room physician wants to talk to you right away. Want to tell you what's going on with the patient. No, this one says, don't listen to him. Here's me. The angry patient wants to talk to you right away, right? Here he's saying, my God, the patient wants all these forms filled out right now. And then, of course, my medical assistant, patient is in the room. Doctor, please get into the room to see the patient. Patient is getting very angry. This is the plight of primary care, my friends. Thank you. All right, so now I've depressed you with my talk. And so next is going to be Dr. Prabhakar. He's certainly going to perk you up, I'm sure. Here is Dr. Prabhakar. Provocative promises of future healthcare. Thank you.
Are you guys depressed already? Okay, let's go and look at the positive aspect of healthcare and the issues what we found, we can find a solution. Otherwise, our country is going to be a third world country, worse than third world country, the way healthcare is going. But promising AI and other things are coming up. Let's discuss that. Provocative promises of the future healthcare. So these are the topics I'm going to be talking. So I'm going to briefly tell. Next slide, please. Articles about AI in 2015. AI articles were 2,500. 2,500. In 5 years' time, AI in medicine, as articles published, skyrocketed to 700%. Okay, to almost 20,000. Doubling of medical knowledge. Medical knowledge is not expanding, it is exploding. Medical knowledge now today is exploding. It's unbelievable knowledge we are getting. And 1950, it took about 50 years for doubling the medical knowledge. In 1980, it took 7 years for us to double the medical knowledge. In 2010, it took about 3 to 5 years. Today, it takes about 2.5 months. Unbelievable development, unbelievable knowledge. No human being, human brain can comprehend and manage that. Next slide, please. Organ transplant. 10 years ago, we had only heart transplant and kidney transplant. Now, we have all these organs we can transplant. Guess what? For the past 3 years, we can transplant heart, lungs, and liver together at the same sitting, same surgery. Heart, lung, and liver they'll do a transplant. Next slide, please. Regenerative medicine. I would like you to take you to medical school. So, we are all conceived from one cell, right? Ovum and sperm join together and create the cell. And it multiplies. And over a period of time, 3 sets of cells are created. Ectoderm, endoderm, and mesoderm. Ectoderm is the one which develops into skin, scalp, and bones. Mesoderm is muscles. I'm telling you for a reason. Next slide, please. When I had a heart attack, blood vessel is not going to the heart muscle gets damaged. So, scar is formed and the heart is not able to contract, thereby resulting in heart failure. All these years, we were not able to do anything at all. Today, next slide, please. You remember I was telling you, the embryo develops mesoderm. They are able to isolate the mesoderm and culture the mesoderm in the lab. And cardiac muscle, they are able to culture. And that tissue, they are able to go there and cut out the scar tissue and place this developing lab-created muscle and implant there. And the green one, what you see, is an implanted cardiac muscle, which is created in the lab. And the black one and red one is scarred. It is just growing into that. So these patients never get heart failure. Next slide, please. You know, when a patient gets a stroke, they can get paralyzed one side or they cannot speak. The speech is managed by left side of the brain. It is called Broca's area. So when a patient has stroke in that area, they'll be able to do everything, but they may not be able to talk. You ask a question, they know the answer, they everything. They can even write it, but they cannot express themselves. Guess what? Now we can implant a chip inside the brain that listens to the message and looks at the brain cells, how they communicate, and finds out what the patient wants to express. And that particular thought is printed in the computer next to the patient's bedside. Like a fiction, like a story. This is happening now. Next slide, please. Same way, this guy had a spinal tumor that was resected, and he became paraplegic. And he was not able to walk for 5 years. What they did, they implanted a chip inside the brain, and outside there's another equipment. They communicate with the chip inside, and after that, it stimulated the muscles, the nerve brain part which is controlling the lower limbs, and the patient immediately is able to walk 100 meters and was able to climb the stairs. Isn't it something? It is unreal. Next slide, please. Neuroprosthesis. The patient is paraplegic, and they put some prosthesis here, and again the same way they implant some chip there in the brain, and outside another one which is controlled by the scientist. And what do you want to do? I want to grab a glass of water. So go ahead and do that. And she's able to go there and grab the water. She was paraplegic until then. Okay? It is beyond imagination, guys. Next slide, please. 3D printing. 3D printing, this girl had, at her birth, she didn't have any development of the arm. So she was given a 3D printed arm and fingers and everything. And she is able to tell her left arm to go and grab a bottle of water. Next slide, please. This is again, I would like you to focus on what I'm going to tell. There are 330 trillion cells in our body. I'm repeating it. There are 30 trillion cells in our body. There are 200 different types of cells in our body. 1 million cells die every second, and they are replaced. Red cells live about 3 to 4 months, but the white cells live for a year. Totally bizarre. And since we have 30 trillion cells and they are all dividing in different time zone and rates, naturally 1 or 2 things cells will go astray and they will go out of control. They'll start multiplying very rapidly, and that's what is cancer. Another fascinating story. Every one of us here sitting in the room, we have cancer cells almost every month. Our bodies going astray, 30 million cells. Something goes astray and we are getting cancer every month. Fascinatingly, our immune system is so brilliant. It goes and detects which cell is going out of control, and immediately it goes and destroys those cells. And that's the reason why most of us don't get the cancer. People who get the cancer are the ones which it goes out of control, and that's the reason why they get the cancer. And guess what? T cells are the ones. T cells are lymphocytes. One type of T cells is called lymphocytes. They are the killer cells. What they do is, our immunity goes and identifies the cancer cells, and it sends a message to the T cell. The killer T cells go there and destroy the cancer. Next slide, please. Guess what? Now we have the ability to give immunotherapy. You may remember when a patient gets a cancer, all these years, 30 years, 40 years, we'll give chemotherapy. You might have encountered people. Patients with chemotherapy will lose their hair, will have a lot of mouth sores, diarrhea, vomiting, and everything. The reason for that is we need to give the highest dose to destroy all the cancer cells. But it has to go and affects the normal cells as well. That's the reason we get that. But when you do immunotherapy, it just goes and induces the T cells, T lymphocytes, and that goes and destroys the other cancers. And that's how we do that. That is immunotherapy. Fascinating. This is again phenomenal. You guys are familiar with DNA, right? Every cell has got nucleus. Nucleus has got DNA and RNA and all that, right? DNA is nothing but a strand which is made up of amino acids in continuous sequence, in a certain sequence. And that one goes astray, and that's the one causes the defective issues, genetic problems, such as hemophilia, beta thalassemia, and muscular dystrophy. Now, they are able to find out exactly how this DNA chain is, and now they have the ability to send the appropriate way the DNA should be and penetrate into the DNA and change the whole construct. And so these patients can live happily ever after. Phenomenal, phenomenal. All the fictions are coming true today. Next slide, please. CRISPR technology is a mind-boggling technology. So DNA sequence gets destroyed. And that's the one which causes a lot of the problems. Now they know they can synthesize exactly how the structures should be in the lab. And they incorporate that structure into a virus, benevolent virus, and they inject it into the patient's arm. And the virus will go and attack these cells, the DNA, and transfers that particular appropriate strand there. So the defective DNA is removed, the good DNA is there. The fascinating thing is, these DNA, since we sent it, we were able to manage from outside. We are able to manage, we are able to get messages from there, exactly what's happening. Next slide, please. Same thing, it's altering the behavior. Next slide. Now we know exactly how the myocardium, heart muscles are there, kidney muscles are there, everything. So we know exactly how the amino acids are produced. So now we can synthesize different muscles. When the heart attack happens, they can cut that scar tissue and synthesize the cardiac muscle and put it there. Okay? It's called bioengineering. Next slide. There are several devices. I don't want to go over everything. It's unbelievable amount of information. The patient is going there and we get all the information to our doctor's offices in the hospital. Next slide. Next slide. This is patients with Parkinson's disease. They have a tendency to walk in a weird manner and they will fall down. They have a tendency to fall down, keep falling down. There are some computer chips are incorporated into the shoes. That the other one also, they talk to themselves. They know exactly how the patient is walking. They send a message. It's a wide-based walk. How the patient trips and falls down. 2 or 3 times he trips and falls down. Exactly what is the mistake he is doing. It sends a message. So physical therapist can come and they can train exactly, don't do it that way, you do it this way. So simple microchip in the shoes. Next slide, please. Contact lenses. It can detect glucose level, diabetic patients. Put the contact lens, and in your iPhone, you'll get the numbers anytime you want. One thing. Okay, ocular pressure. If the increased ocular pressure is there, it can cause glaucoma, and that can cause blindness. The retinologist will get the message, so they can change the medicine or increase the dose. Next slide. Same way, headband will monitor seizure activity. Seizure convulsions will occur only if it goes beyond certain level, but all the seizure activity is recorded, and neurologists will get the message. So depending on the wave, they can adjust the dose of the medicine and add medicine and all that, so it can treat. Next slide. Aura ring, it not only checks the heart rate, oxygen saturation, temperature, and sleep pattern. Sleep pattern is for sleep apnea. Sleep apnea is one of the commonest causes of death during sleep. This has got so many medical issues there. Next slide. Robots can supply medicines in COVID area. Next slide. During COVID, many of the doctors were affected. They were all in, they cannot come to work for 14 days, 15 days, so only skeletal doctors were there, and they don't want to get infections. So they sent a robot to the ICU, and the patient is talking to the robot, and the doctor is able to talk to them, and their conversation are transcribed. Next slide. The reception. Doctors' offices, California increased the payments rate for everybody, $20 or $25 an hour. Primary care physicians, or even the little bit of people, everybody will go bankrupt. This is one of the options. Okay? The robot can stand there. The moment you come and give your driver's license, immediately it pulls your chart, asks all the questions, takes the patient to the doctor's office, waits there, and when the doctor checks the blood pressure, pulse rate, everything, the doctor comes and talks, it is transcribed, completely it is transcribed. Okay? Next slide. Stethoscope. It is unbelievable. Echo stethoscope. As a matter of fact, the previous slide, I forgot to mention to you, there's a company in New York. Last weekend, I had a talk with them, and they wanted me to be the director in that company. It's unbelievable. The progress they made is unreal. The EKG step is called echo step. Patients who are obese or patients with a large breast, we won't be able to listen to the heart clearly. So it is very, very important to know the murmur and any arrhythmia they have. Not only that, we can increase the volume so that we can listen properly. We can see it in our phone. All the entire EKG. I don't have to stop everything what I do, go out and tell my staff to come and do an EKG. EKG is right away there. And guess what? During COVID, when the doctors could not come inside, they had the earpod, and patients, they told mark the chest wall, exactly what to put. They gave a stethoscope to them. They put the stethoscope there, and doctor was listening from the corridor. Okay, heart sounds. Go to the next one, because robots are there. Through the robot, they'll say next one, 1, 2, 3, 4. They will write. So they go to the next one, next one, next one. Okay? It is all about that one is volume, and this one is for EKG. That's everything, the whole concept. Next one. Now we have sophisticated watches. We can predict cardiac arrhythmia. There is a condition called paroxysmal atrial fibrillation. What it is every now and then the heart will go very, very fast. Early detection is crucial. That's one of the commonest cause of stroke. Once they have a stroke, nothing can be done. Once you have a stroke, you can only prevent. Next slide. I'm going to skip it. Next slide. Artificial intelligence. Now, let's go back to the sobering story of the first speaker. Okay, depressive. Okay, the primary care doctors are suffering and there is nothing, not a doctor. We're all replaced by PAs and nurse practitioners. This is going to be immense helpful. Again, as I mentioned to you, one brain, all my experience and knowledge, I would have seen about 10,000 patients. I make a diagnosis with my experience knowledge. The medical records are billions, millions, and medications are millions. Every single thing, everything is millions. AI can go and completely review everything and give you the answer. When the patient is, you ask the question, doctor asks the question, find the physical findings, immediately he tells you, these are all the possibilities. Diagnosis, these are all the medical, also transcribes. Labs, what are the labs and x-rays you need to do for this patient? What are the possible differential diagnoses? Everything, it just tells you. And the quality measures, she was telling, quality measures we have penalized. This one will tell us, give us information. Treatment plan, what are the possible plans? So you can go and choose which one is the appropriate one. It is amazing. This is going to, all of us are going to retire and all of us are going to feel the same way someday. And this particular thing is going to save our lives. Next. A variety of different things can be managed with this one. Next slide. Computers learned the computer chess game. Within 4 hours, it was meeting the world champion in chess. It was beating. Next slide. Pathologists, now we rely on them tremendously because it's very, very important. Next slide. This patient went to the ER. The ER doctor looked at the CT scan and the patient was complaining of chest pain and shortness of breath. CT scan, there is no pulmonary embolism. So he thought that the patient may have heart attack, heart pain, so he wanted to admit. But the AI says, no, the patient doesn't need admission because he has got a fracture in the rib. So they put a Band-Aid and send the patient home. $35,000 is saved. Next slide. This is COVID, patient with COVID pneumonia went to the hospital. The ER doctor wanted to admit the patient in COVID area and give COVID medication. But the AI said, no, stop it. And it's a pulmonary embolism, blood clot. That's going to be fatal. So start the patient on blood thinners right away. And then you admit the patient. Next slide. All these equipments, radiology, MRI and all that, they got approval from FDA. Next slide. Bronchoscopy. Bronchoscopy, the tumor is here. If the tumor is here, they're not able to reach the tumor. So the pulmonologists are not able to go reach there because all these, this is trachea, this is bronchus, this is bronchioles, this is all very thin. So they're not able to reach the tumor. But now we have sophisticated AI-driven bronchoscopy. Doctor doesn't have to look at it through the hole. It's a big screen. They can just look at it. And they go there, it emits ultrasound and detects where the tumor is. And then it directs itself, it writes itself. Just like in San Francisco, self-driving car. Just ultrasound and goes exactly where the tumor is. It goes directs and then goes there. And they can take a biopsy right away. And the pathologist is sitting in the operating room and he sees, yes, it is a cancer. Immediately, the same scope, same ultrasound, it goes there and implants radiation needles into the tumor to radiate completely and cure the patient. Isn't it amazing? Next slide. This is robotic surgery. Doctors are just watching. Okay, you do the surgery, you just direction. Next slide. ChatGPT, you heard about it, right? It passed the medical exam. USMLE with 90%. With 90%. Okay, next slide, please. I want to show you Nuance. It is bought by Microsoft. She was mentioning about the hardship of typing notes when the patient is sitting there and showing our face back to the patient and then typing, patient is not happy, I'm not happy, and I have to go back and go and type and all that, right? So with Nuance, you can just talk, chat with the patient. So I'm not able to show the demonstration. Basically, when you click here, I'm not able to do that. So basically, to show, one of the ladies coming with a knee pain. He is talking, the doctor is talking. Whole screen of EHR. As they are talking, they talk about vacation, it doesn't do anything. They talk about the knee pain, it strikes, right knee, left knee. And then findings, he says, immediately tells the diagnosis, what are the possible diagnoses, what are the possible tests that need to be done, everything. So it's already in play, already in EHR. So even though they are PAs and nurse practitioners, hopefully in the next 3 to 5 years, everybody will incorporate this and hopefully we'll all get good. Next slide, please. Oh, that's okay, Next slide. 7 minutes 7 minutes per patient we save. So again, to her point, 7 minutes we save, 2 hours per day we save. So enormous amount of benefit. Okay, because of that. Okay, 70% reduction in burnout. Anyway, everything is good. Next slide. Okay, drug discovery is amazing the way we have done. Next slide, please. The older patients, they forget to take the medications, and alarm is built in. The family members can put the medicines and put a bottle of water. Alarm goes off. They go and turn off the alarm. The red light comes. He just takes that medicine, takes it, and put it. Next thing will go. Next slide. I want to give you some sort of idea. Everybody knows about our regular computers. The enormous, massive database we have. Do you remember? I was telling you, pathological thing, massive database. In order to process some of these complications, it takes about 8,200 years for the regular computers to compute. Whereas the quantum computer solved it in 3 minutes, 20 seconds. Next slide. This is the NVIDIA GPU. We use CPU, this NVIDIA GPU. Processing power is enormous. In 2023 to 2017, 13 to 17, look at the skyrocketing power. And 2013 alone, just look at that, the amount of maximum power these NVIDIA AI chips have. Next slide, please. The exciting future of the exploding technology in healthcare is yet to unravel. Next slide. Thank you for your attention. Please clap. Okay, we saved Harish's speech as a last because he is a dynamic speaker. We want to end the talk with a bang.
Good evening, everyone. I'm sorry for this lady, to be honest. And it's a tough act to follow. Someone like Sandeep, followed by Harish, and then you got Farris, and now you had Venu. So, but the tea is still hot. So if anyone wants to quickly take a quick break and get some tea. I'm promising not to take much of your time. I think I want to thank TiE, particularly Naresh Soni and Sandeep Verma, without whom I wouldn't be here at this time. I typically sleep at about 8 o'clock and wake up at 4. And so, but good. I'm glad to be here. I'm going to tell you a few stories. You watched in the previous talk, and you're technology folks, you are the ones who are going to make the stuff for medicine over the next 50 years. But you really want to know what happened in the last 125 years. Unless you know history, you will not know where to go next. All those 50 slides before me talked about what you could bring to the table. How implementable is that? How can you bring it to the grassroots system? How can insurance cover for this in this country? Let's talk about a few things. Next slide, please. What do I do for a profession? I'm a human carpenter. My job is one statement: life is motion, motion is life. I keep all of you walking through your course of life. No one wants to get onto that last. No one wants to be on the right side of the curve. But you know what? All of us eventually get there. And our job as orthopedic surgeons is really to make sure that we support, sustain, and keep the musculoskeletal system going through this process. Orthopedics is not a very old specialty. You know, Sir Nicholas Andrew started orthopedics back in 1741. So it's not a terribly old specialty. But if you really look at medicine in general, everything that has happened in medicine really has happened in the last 125 years. And I'll tell you a few anecdotes as to how disruptive medicine is. And particularly for engineers, because you follow some things, you follow these statistics, you think something can be done for something, and you try to push that industry in a certain way, and you expect to make a lot of money out of it. And then boom, disruption. So let's give some examples of disruption. Next slide, please. Before I go to that, look at these slides, and these are the slides which make you glisten up as an industry person or a technology guy thinking, wow, if 67 million people are going to have arthritis in 2030, maybe 120 million are going to have arthritis by 2050. So maybe I should do something to develop, advance something and put money on that horse, if you call it. But hold this thought because I'll come back to it in a little bit. Next slide. Clearly, we've come a long way in your segment. How many of you remember the left hand of the slide? I come from India, so I do.
Marty?
Yes, of course. Of
Hey,
course.
by the way, he's our charter member.
And that's purely on my slide because of Marty. But having said that, from there to this has been a long journey. But similarly, medicine has moved, although slowly, in a very good manner as well. Next slide, please. Same thing in the auto industry. To go from there to this, and as my friend Nakul from Qualcomm will tell you, something else is exploding in that space. And again, you're going to go beyond Elon Musk very quickly. Next time. But look at this. And this is a disruptive industry. What am I showing you? Poliomyelitis. How many of you know this condition called poliomyelitis? Yes. So poliomyelitis, until 1880, nothing was happening in the medical world until Lister came up with antisepsis. And then between 1880 and 1926, lots of knowledge came about for microbiology. We started figuring out what causes what, viruses, bacteria. 1926, Fleming comes up with penicillin, disrupts the industry. But by this time, when polio was diagnosed, understood, a big industry developed for making braces, rehabs, admitting these patients. Boom comes Salk, 1952, vaccine. 1977, polio is out of the United States. Gone. You don't have a single case, a new case of poliomyelitis since 1977. So all the industry that was working at the time on these bracings, developing them, making them better, making them less heavy, all these sanatoriums that were developed for admitting patients with poliomyelitis, tuberculosis, leprosy, fell apart. Anybody knows the oldest hospital in San Diego? No. The oldest hospital in this city. Anybody knows? Anybody living here for the last 40 years?
Yeah.
Which hospital is the oldest hospital in San Diego? Scripps Mercy Hospital. 1890. What was it at the time? A sanatorium. The second oldest hospital in San Diego. Anybody? We don't know our own city. We are out to conquer the world. The second oldest hospital in San Diego was Paradise Valley Hospital. What was Paradise Valley Hospital in 1910? A sanatorium. Okay? Disruption. Next slide, please. This is a beautiful line. And that's because those my medical colleagues sitting in here will know the term standard of care. In medicine, we use something called standard of care. Malpractice lawyers love that line. Because if you fall below the standard of care, and attorneys are sitting here too, so they'll realize you're negligent. And because you're negligent, you cause harm to somebody, you should be sued. But do you realize that this word standard of care continues to change? That what is the height of absurdity in one generation becomes the standard of care in the next generation. In 1940, when Kunchar was putting rods into the femurs in the American soldiers during the World War and sending them back to the United States, everybody thought he's crazy. He's a crazy German. But when these boys started coming back and we took x-rays, we realized, holy cow, there's a rod inside. And these kids are able to walk again. Internal fixation of fractures. Prior to 1960, all patients of fractures had to be admitted in the hospitals and had to stay in the hospitals for 3 months. Get castings, tractions. Then came Muller in Switzerland. And it started a small company called Gemeinschaft für Osteosynthesis Fragen, which came to be known as Synthes. 1960, Synthes was formed. Why was it formed? For internal fixation of fractures. And in 2020, I believe, or maybe earlier than that, Synthes was bought by Johnson & Johnson for $21 billion. Phenomenal industry. We changed the practice of medicine. Disruption. So all those places, the castings, the admissions, the tractions, were the standard of care, and boom, changes. Okay? Next slide, please. Let's go back to the same old story, same thing. I mean, at some point in time, this was the standard of care. If you got an infection, a bad infection, a gangrene, chop it off. Amputation. And then, like I said, Lister came up with antisepsis, and then Fleming changed the world. And today, the standard of care, every single surgery conducted in the United States, which is not a soft tissue surgery, gets 1 dose of antibiotic before surgery, 60 minutes before. Prevents infection. Change the standard of care. Right? Next slide, please. So these were all those sanatoriums, rehabs, admission places. Why am I saying all this? Because go back to the same statistics. You are expecting 120 million people to have arthritis by 2050. And I'll tell you, sitting here today, you won't have those people getting arthritis. Anybody can tell me why? What is going to disrupt this?
Gene therapy.
Possibly. What is already existing that is already causing a disruption? AI can do nothing. No. Early detection has got nothing to do. I'm talking about what is modifying. What is modifying? Have you all heard the terms these days called longevity, wellness? Yes. Slowly erupting. But more importantly, have you heard the term biologics? Yes? Venu touched a little bit on that in terms of stem cells. Not as much reliable data today, but there's something called PRPs, plasma. Your own body's cells being used to repair itself, to maintain, continue the nutrition of cartilage, to to delay. Remember, you cannot eliminate death. You cannot eliminate aging. What people are working on is delaying the process of aging. Yes, if you can delay arthritis to a point where it's about 70, 75, nobody wants a joint replacement at 75. Have you asked any of your family members who are more than 75 about replacements? Many of them will be like, I don't really want to do a replacement at this point. So I mean, that's an interesting concept too. But my point is, wait for disruptions. Don't calculate, don't put your eggs in a basket where you think AI, this, changing the industry, let's bet on the next horse. And I'll show you certain advances in orthopedics now, where we are obviously advancing within our field itself, but I really want you to take home that one concept. If you're a young entrepreneur, particularly working in the medical field or trying to advance the medical field, remember, there's always going to be an Alexander Fleming. There's always going to be a Salk. There's always going to be a Mueller. There's always going to be a John Chanley. When John Chanley first described the hip replacement in 1960, they banished him from the society for 3 years. They said, you're crazy. How in the world can you cut a ball and put a metal ball in a plastic socket in someone's body and expect that to be the standard of care? In the United States today, we do 800,000 hip replacements a year. Standard of care. You see what I'm saying? 1960 to 2000. Standard of care changes. Industry is disrupted. But having said that, as I say, joint replacements are not necessarily going to be multiplying exponentially. You out the whole concept of healthcare, insurance, coverage. That's a completely different issue of discussion on some other time as to what is going to be covered and what's not going to be covered, how much money is going to be left in the healthcare system to even give you any of these things. Next slide, please. Next slide. I think Venu touched on all of this, so I'm just going to move forward with this. Yes, advances are absolutely phenomenal in our industry. A 3D printed meniscus. It's there. For how many people is it available? We don't know, but it's there. And I say this from the premise that my first 17 years of my practice was in academic institutions. And the last 11 years in a full private concierge practice that does not take insurance. So it's an interesting concept, and if there are questions I can answer on both sides of the aisle for you, but this, to come into an insured patient base, is impossible at this stage. Next, please. 3D printing, robotic surgery, yes, this is exactly what's going to come in, and this is where a lot of engineers, technology folks, are going to put their money on, is that, okay, great, 67 million, 120 million, 180 million, but just make sure you're not counting your eggs in that direction, because there is disruption that's going to come and disrupt this part of the equation. But today you're able to do customized implants. It's not as if it's a genetic implant, one size fits all. We design implants to fit your body, your system, and your motion. Next slide. Endoscopic surgery, yes, we put small holes, keyholes, you know all of this stuff. I think everybody's familiar with endoscopic component. Next slide. And robotic surgery that Venu talked about. Next slide. But just understand the fact that robotic surgery is not as if robots doing the surgery. There's still a surgeon at the end. Because why? We have lawyers in this country. We need to sue somebody. So we can't sue the robot. We could someday, just like we're going to sue Elon Musk for all the automated cars, and probably sue some AI industry for a commercial policy on every vehicle. But the bottom line is, there's still a human being with a license in that state, within the United States, that is conducting that surgery. Next slide. And watch this space. In my opinion, this will be the biggest disruptor of this century. I want to leave you with that thought, but watch the biologics. And this is really, if you think about it, it's really those guys who sit in the lab, who work on biologics, that have always disrupted. No disrespect to engineers sitting in this room, but remember, it's the biologic guys who will always create something that would change, because at the end of the day, a human body is a machine, which is a biological machine. So as much as you want to put engineering implants into that, it's still a biological machine. It's 30 trillion cells put together, which is working in synchrony as an orchestra to help you move. And therefore, life is motion, motion is life. Thank you for your attention. Questions if you have any? Yes.
Can you explain this slide? What is happening there? You're extracting and then inserting?
So ACI, autologous chondrocyte implantation. This is very well perfected at this point. What is done is particularly done for the knee joint. We go in first, and in the first time, extract the cartilage cells from your own cartilage in the knee, and in the lab, those cartilage cells are grown. And then after that, you come back in a second surgery, and you transplant that cartilage. So this is ACI, autologous chondrocyte implantation. Works phenomenally for the knee joint, has not done as well in other joints so far. But it will get there. Yes?
Question on PRP.
Yes.
How effective have you, in your practice or in your work, PRP in resolving issues with, any type of, arm, like shoulder issues or knee issues?
Great question. And our practice takes pride in being the highest volume PRP in Southern California. Between our entire group, we do that many PRPs. There is reasonable clinical evidence as well as results for PRP for muscle, tendon, ligament problems. For example, in your terms, you have a rotator cuff tear. You have a labral tear in the shoulder. You have a tendon injury in the shoulder. You don't need to jump into surgery. You have a meniscus tear in the knee, or a quadriceps tendon partial tear, or a patellar tendon injury. You don't need to jump into surgery. You play golf or tennis and you have a bad tennis elbow. You've gone to your primary care after those 6 months of waiting that Farris told you, and eventually got a cortisone shot. That's not working. You don't need surgery. Level 1 evidence, PRP will fix that problem. You have Achilles tendinitis, plantar fasciitis, PRP will completely fix that problem. It's advanced. It's advanced treatment. What do we call it? It's the Neiman Marcus of medicine. And yes, is it covered by insurance? No, hell no. How many of you wear a Jimmy Choo or a Chanel bag? When did you get that on a discount at Target? Never. You're never going to get that. You want a Chanel, you go there, you pay $6,500 and you walk out of the store. That's what it is. You know what you're getting, but you pay a price for that. And I'm not belittling medicine, but honestly, advanced medicine is expensive. But there are results, and they're predictable results with PRP. Great question, but yes, there's lots of places where PRP can work. Yes?
You said that 3D printed meniscus is not going to happen it implied that it is too expensive for the, foreseeable future. Is that
correct? Let me give you a simple example. The first HMO system in the United States, started in which state? Perfect. Which city? No. Los Angeles. You know how much money was being paid a month for coverage? A month for coverage for the first HMO system in 1929. Anybody? $1.50. $1.50 a month. $1.50 a month was the contribution to get full coverage in LA County in 1929. What does $1.50 get you today? Nothing. Right? So bottom line is, it was a different there is no way the current healthcare system can support a $50,000 printed piece of cartilage. It just cannot. Is the technology there? Yes. Is the technology applicable to the masses? No. But yes, it all depends on, it's a numbers game, right? So eventually, who knows where and when we will get into a nationalized health system. But the money is bleeding rapidly, so don't believe me, the healthcare system is such a big black hole. It is one of those things that can drag the entire economy down.
Okay, anybody? It's open to all the questions. Anybody, you can ask questions now.
question.
Yes.
You are such a professional dynamite speaker. Have you done the TED show, the TED Talks? Have you thought of becoming a professional speaker and charge $100,000 for the lecture? You are such a...
I have decided to give all of those rights to Sandeep. Thank you for your kind words. Yes, sir.
Can I say one more thing?
Yes.
So, we talked about a lot of things around medical, a lot of doctors here, a lot of technologists, a lot of biologists. But the key thing that people are forgetting is there's only so much what doctors can do, right? We have about close to 20% of our GDP going to healthcare.
50.
Compared to Finland,
Close to.
which is about 2.5%, right? So that's about $4 to $5 trillion. When you think about this whole thing, there's a lot of responsibility we ourselves has to take, because the doctors can only do so much. You can get a lot of your physicians, your primary care, if you have cholesterol, they'll give you cholesterol meds, make sure you're exercising, eat right. So there's a lot of things that's going to belong to us as human race about wellness. And in terms of disrupting technologies and the future of medicine, there's a lot of work that's being done in the startup industry. AI, one of the things, but then it also comes down to a lot of the models and wellness models, predictive models based on not just the information from the past that we're gathering from the data perspective, but also is the other side of it, like calculated care, that you take the past data and you make informed decisions about what the future is going to hold, which uses AI technology and a lot of the wellness. So I just want to make that point. There's a great book from Peter Lee called Evolution of AI, with ChatGPT-4. I think you should all read, people in the medical industry. I recommend it.
In terms of, that's a great point. In terms of evolution of medical care within our country, the biggest setback, in my opinion, that happened to our country was in 1970. You know what happened in 1970? No, Medicare actually was established earlier. What happened in 1970 that destroyed, in my opinion, the healthcare system? Anybody? This beginning of what is called as a health managed, correct, HMO.
That actually
Managed.
happened in 80s. That happened.
No, I think that 70s was the initial opening of
Yeah,
the
but the
HMO
main
system.
push came through.
Correct. I mean, if you really go into semantics, 1929 was the first thing.
Yeah.
Then the Kaiser system was kind of an HMO
And there
in
are
45.
that came
And then
in.
you came around in 70s when the real, in 32, Blue Cross started its
Yeah.
own system. So I mean, but Blue Cross was not an HMO. The
But
real
until then it
HMOs,
was-
managed health cares, came around 70s.
But until then, it was a cost plus.
Correct. No, even today, cost plus is the way hospitals make money, by the way. Cost plus is the way hospitals make money. Anyway, that's a great topic to discuss some other point. Finance in medicine. It's amazing. The business of medicine is completely another black hole. But great point.
Yeah, and then there are two more things I want to mention
Yeah.
that,
Any-
you guys
let's
that are in the
finish.
medical industry.
Sir, excuse me.
There's a lot of things you guys can do in terms of changing legislation. Because everything in this country works around law. She mentioned something about, shortage of physicians. Yeah. Baby boomers are going to be needing a lot of care. In 10 years, the baby boomer generation is retiring, less than 10 years. So all these people are getting old with less physicians. And if you don't open up more seats, more institutions for getting your doctorate, then you're going to always have that issue. So not only you need to, and there are some companies that are already doing it from Florida and other states, where they're letting the patients go cross borders to get medicine, surgeries, and things like that. So we need to look at a globalized platform. Also, we need to look at like a unified a database where all this research and things that we're doing, we don't have a unifying data model, right? So,
I think you have a great vision.
So anyway,
I know, my only point is to cut you off is that it's a great vision. Two problems with doctors, just two problems. Doctors don't stick together, doctors are bad with politics. I'm going to stop at that. Because it's a great discussion. AMA is the oldest organization in the United States. It was formed before the century of 1900. AMA started before 1900. In fact, AMA membership went from 4,000 to 70,000 just in the first decade of 1910. But having said that, doctors don't stick together, they're not politicians. So they're never going to lobby for themselves.
I have a comment about what your comment is, the reason for
Take the mic, please.
reduced number of primary care physicians is 1/5 of all the doctors in the United States are from India. You know that? Okay? 1/5. There is one in five. So they've been stopped from coming in. For the past 16, 18 years, they stopped influx of Indian doctors. Indian doctors are the ones who become primary care doctors, majority of the people. They stopped it. And all the foreign medical graduates, they completely stopped it. I don't know why. And secondly, they reduced the number of residency programs. Okay? And with great difficulty, they are giving 200 residency programs for the whole country. Whole country. The deficit is humongous. It's really, really scary. Okay? These people don't care. We want to, and furthermore, we are opening the border. 2.7 million people walked in. All the people are going to get a home, 45 inches TV and telephone, and complete health care, which you and I cannot get. We are taxpayers. They get Medicare, people get everything. Okay, so money is going to be drained completely. I know it's a scary situation. Any other questions?
So,
Just a quick survey. If there are any MDs left here, how many of them think that AI will replace them in 5 years?
So, just like, anyway, so I'm loud enough, I think. So, so just like Harish mentioned, there has to be accountability in this country. Like he said, lawyers, no, physicians cannot be replaced. Just for that one particular reason.
So all these things I hear about AI, cloud computing and so on is just
It will make it easier.
PowerPoint slide?
Yes, it will make it easier for physicians themselves, but no, it cannot be replaced. With this system, the way it works, they cannot be replaced. There has to be an accountability here.
So you depress me further.
That's my whole evening today.
Dr. Sai?
AI is going to help us make a lot of decisions. And also PAs and nurse practitioners, even though they don't have, just like how we were trained, they can do a lot of things because AI will help them. Main thing is dictation. Oh my God, documentation is taking so much of our time. It really drains us. The evening we go home and document. In the weekends we document. We burn out. A lot of physicians left because of that.
Question.
so technology can help in that documentation because you are not typing. I see my doctor, primary care, speaking. I don't know how accurate it is, but couldn't that be streamlined with technology?
It is already coming. Already, majority of the EHR have now incorporated the dictation, transcription program. It is phenomenal now. Okay, I've been using Dragon Dictate, which is the one which Microsoft bought since for the past 20 years.
And still the weekends are paperwork.
Of course.
No. I'm doing far better than other people because I complete the chart while the patient is there. So, and also, patient sits there, computer is there, and then I dictate and I tell them, correct me if I'm wrong, okay, and then they'll correct me. And I just speak into the computer, it just types. But majority of the doctors are not using it, and the patient will be sitting in the back, they'll be looking at the computer and typing. Patients get frustrated because patient satisfaction is not there, and doctor is getting frustrated because I need to finish the job. Otherwise, I have to go on weekend and weekdays and evenings and all that I have to do.
But remember, it's not just documentation, you're doing other things.
Yeah.
You are, documenting is one side, I can certainly do that quickly. Like he said, I do that on the same day, I never am behind in documenting. But then, behind the scenes, taking care of everything else, taking care of their labs, their prescription refills, the messages that you get. And with the smartphones, the messages are so, the volume is so high. You're sitting down there, you're answering this email, and then the next 10 minutes, the email comes back to you. It's a monster.
Sorry.
That's my question.
This disrupts the family also. Family life is also going to get affected. Not only our office work, but family, why the hell are you sticking the computer all the time? So it's a tremendous stress. That's the reason why a lot of doctors are pity.
You gave me a lot of discomfort. I'll tell you what happened to me. I went to baseball game, Petco Park, and somehow I fell down on steps. You know how deep those steps are, and I fractured my back, and I was in terrible pain. Went to ER. They said I need to see the orthopedic doctor. They referred me. I tried to make an appointment with an orthopedic doctor. Guess what the next appointment was? 2 months out.
Oh, you're lucky. Yeah.
2 months out.
You're lucky.
The only one I could see after 3 weeks while I was going through the pain was PA. To this date, that happened in June, early June, I have not been able to see the orthopedic doctor. My next appointment again is with PA. And you gave me a lot of discomfort on PAs. How bad should I feel? How do you make me feel good going back home? Hey, am I in good care?
Well,
There is no other choice.
There is no
other
choice.
Okay? The healthcare system is really, really deteriorating, unfortunately, and it's pathetically so painful for me to say, okay? Because doctors are not becoming doctors. They're not coming to primary care doctors. So it is really, really bad. So all of you should write to your senators and congressmen. Every one of you should write, expand number of primary care physicians, okay? We need them. Everybody tells that. It is really, because all of us need that, one day or other.
So, Harish, you practiced in the UK.
Yes.
Compare it to NHS or Canada or something. I mean, we were told we should not have Obamacare because we should pay and the system is the best. And now the system is pathetic.
Broken.
Is it the same as waiting in the NHS system in the UK where you have to?
Well, NHS was a failed system. In fact, my reason to leave United Kingdom was because NHS was failed. My wait list in 2001 for my patients was 2.5 years to come on my table.
yes.
In 2001, I mean, and so I was like, I can't live in a system where my patient is going to take 2.5 years to come on my table. And I left it and I came to the United States where I saw a failed system as well. So we created a system. At the end of the day, we don't have a wait list. For example, somebody calls my office to see an orthopedic surgeon, they get to see the surgeon same day or the second day, but it's a different system because we don't take insurance. What did I say? The biggest curse to this system was a managed care. Somebody else is managing this for you. And at the end of the day, the provider is not the bad guy, nor is the consumer. You got this middle person. You created that person. He's talking about lobbying. You lobby and try to get the middle person out.
Yes.
That middle person is the biggest shark. It's not going to go away. So yes, I feel bad for him. He's waiting for an orthopedic surgeon. What are you going to do about it? And so at the end of the day, yes, we see most of your top guys at Qualcomm. We see most of the top guys in this city who just call and say, I'm landing at 10:30. I want to be seen at 11:15. Yes, please walk in. And I think that you are going to see a tiered system. Same thing happened in England. Harley Street was created for this. You walk into Harley Street, you see, what do you have to do? Pay £2,000.
Harley Street was 50 years ago.
But it doesn't matter. My point is Harley still is still the epitome of care, right? The NHS exists and there's Harley Street. Go to the Canadian system. There is a national system and there's a privatized system. Nature finds its way. Nature finds its way.
So I should subscribe to concierge service.
You have to. You have no choice. Do you want to fall in Petco Park and not be seen for 3 months?
Yeah.
That's the way to go.
That's the way to look at it, right? At the end of the day, we all are essentially choosing. Healthcare has become a choice. I think we miss the concept of rights and choices. You know what I'm saying? You don't have a right to get a meniscus 3D transplant. Not today. You have a right to get a flu shot. You have a right to get a cortisone shot. But you don't have a right to get a PRP. Does it make sense? So it's a tiered system. It's not an untiered system. So at the end of the day, that's why you have conscious practice. That's why you have these wellness clinics, these longevity centers, which are not really a part of the system. So kind of nature wiggles out and finds its way. You know?
Okay, I have two comments. One of them is from UK and from Canada. I've seen many new patients. They come and say, I have chest pain, I have angina. They're not doing a bypass surgery. It's going to be there in 2-3 years. If I'm alive, they will do a bypass surgery. Okay, can you help me? I said, go to the emergency room. Tell them that you have chest pain. It's done. Next day, he has a bypass surgery. Okay, so that's what it is. What is the second point?
Well, they're talking about wait time, basically.
Right.
His concept was why has system failed in Canada and the UK?
I mean, we were told that
they're not failed. If you think about it, they're not failed systems. They work for the citizens of that country. It's a nationalized system. It's just that the wait times and everything, it's like, you have to realize we all have reached the part because of this thing of instant gratification.
Sorry.
The frustration of waiting for 3 months for an appointment is there because you're like, why did I not get a text? But if you need that instant gratification, you understand in our country, at least the way healthcare system is going, you are going to have a separate system that accommodates that. You know what I'm saying?
Mm-hmm.
I mean, can AI read my MRI or do I want the chairman of our radiology at Sharp to read my MRI? I have to decide at some point whether I'll pay $20 to the AI machine or I will pay $180 to get my MRI read by the right person. And it's a choice. Someday AI might be better. And he might say, I might get AI to read all the MRIs too, but we don't know that. Today, I would rather that he read my MRI. You know what I'm saying? So it's a choice, and it's, like I said, disruption continues. You know?
One other point I want everybody to know, okay? We are all taxpayers, okay? I told you about medical advancements, enormous amount of medical advancements. We have medications for diabetes, but first thing is, they prevent heart attack by 20%. They reduce heart attack for 20%. They reduce stroke for another 15-18%. They prevent hospitalization for another 20%, something like that range, and prevents death. And incidentally, it helps in diabetes too. Guess what? All the taxpayers, we cannot afford. Our monthly copay is $350. They are on 3 different medicines, 5 different medicines, $2,500 per month. Guess what? Our Medi-Cal system, everything you write, all the 5 medications you write for them, all the Medi-Cal people, they don't have to pay a penny, they don't have to get authorization.
All covered.
Everything is paid by our state, California. California pays every Medi-Cal people. We, senators and congressmen, are not running the country. We, the taxpayers, are running the country. Because of our tax money, they are running the country. But we don't have any control. We are penalized when you are working. We are penalized when you retire. Unbelievable amount of thing. We have only a little bit of savings. We cannot pay. We cannot pay that.
One sentence, sorry. I just want to say, in US, the training is so good. This country produces not one of the best physicians in the whole world, right? But the system has to change. Like Harish was mentioning about concierge medicine and then pay for service kind, you privately pay. Not everybody can afford this. We have to change the system. Who's going to change the system? What's going to happen? That is a big question here.
So one last question I have. I think through the whole evening, we did not talk about allergies. Everybody in the world has allergies. And are we going to eradicate allergies?
Okay. Sameer,
Yes.
Have to answer that.
Sure, all right. So, for those of you who don't know, I'm an allergist, and so that's why that question came up. Thank you, Naresh.
Were you in that picture? That's what I want to
During my residency days,
That's a residency picture, I took it.
So, but yeah, no, allergies definitely. I think in the next 20 years, the technology is definitely progressing so that we can definitely cure, eliminate, or at least significantly reduce the burden of allergic diseases. And I look forward to when that day happens. So, with that
Thank you so much, because everybody has some kind of allergy.
yes.
But let me tell you, we had a great evening today. I think what I want to do is, I think this is so important, healthcare and panel that we have today. We have someone distinguished in the panel. She is going to be the incoming president of SAPI, which is the physicians organization, one of the premier physicians organization here. And I would like her to speak a few words, how TiE and SAPI will work together.
Certainly we need to work together. I'm all for it. And of course, when the race came there, that is one of our priorities here. So how TiE and SAPI can work together is, first of all, I know TiE is an entrepreneur organization, right? So you can really help us, our kids. They can come to you. They can come to Sandhu, right? And then they get on with the training to become the future entrepreneurs. So that is my goal with bringing on SAPI and TiE together.
Thank you, Farris, and I like your vision, and I think we'll definitely work together. And thank you, everyone. But before you leave, there is a raffle ticket that you have, and Mamta.
I don't know, we might have to go through.
So I think there are some prizes. Oh, tickets, all right. Yeah.
No, there's no more photo.
Hey, you guys, real quick. JS, quick, listen up.
Yeah, so at TrueView, we basically do blood, At TrueView, we basically do blood testing, so we do basically what amounts to being an annual blood test in a few minutes. So what I would like to do is offer for each one of you who wants to be there on Children's Day coincidentally, November 14th. We're going to have an open day, it's a wellness day. You guys are welcome to come in. We're going to have a bunch of phlebotomists. We're going to draw your blood and give you your results. And we're in Campus Point Drive, so I'll send the information across, and we can probably give you guys an email or something to that effect.
Jeff, would you send information
November
to...
14th.
November 14th.
Would you send the information to Vinay so he can put that in the newsletter?
He can blast it.
Yeah.
So we're going to do a
Naresh,
comprehensive.
can we get the panelist group picture?
Excellent. Thank you so much.
She's going to draw the... Yeah, the group, okay, go and draw them, yeah.
Do you want to do that first? No. Okay. So ticket ending in 9827. What was the number? 9827.
Ajay, did you get a ticket? Please check.
872